Welcome to this webinar on Pharmacogenetics guided therapy in mental health and its implications for clinical practice. It is well known that finding the right antidepressant can take too long for many individuals. Evaluation of antidepressant efficacy in the treatment of major depressive disorder usually takes more than 4 weeks, and 60% of patients do not show significant remission after 12 weeks of treatment, even with a sufficient dose of antidepressant. The STAR-D protocol provided a series of randomized controlled treatment trials in a broadly representative group of outpatients with non-psychotic major depressive disorder. The design of the STAR-D study reflects what is done in clinical practice. The STAR-D report was published in the American Journal of Psychiatry in 2006, comparing the acute and longer-term treatment outcomes associated with each of 4 successive steps. The 4 levels in the STAR-D protocol tested a different medication or a combination of medications for a 12-week period to assess efficacy of the drug. When treatment at one level did not adequately treat a participant's depressive disorder or they experienced intolerable side effects, they proceeded to the next level with a different medication, reflecting what is done in clinical practice. In level 1, only about 1/3 of the participants reached remission, and the other participants moved on to level 2 with either an augmentation or a switch in the medication. In a 2008 article in CNS Spectrum, Kemp and co-authors commented, "Since depression is associated with substantial morbidity and family burden, it is unfortunate and demanding on health resources that patients must remain on their prescribed medications for at least 4 weeks without knowing whether the particular antidepressant will be effective. Studies have suggested a number of predictors of treatment response, including genetic markers." The next 2 slides list some commonly prescribed antidepressant and antipsychotic medications for which genetic markers have been validated. Citalopram, amitriptyline, venlafaxine, and fluoxetine are commonly prescribed antidepressants metabolized by polymorphic enzymes. Citalopram is extensively metabolized by CYP2C19, while amitriptyline is metabolized by CYP2C19 and CYP2D6 enzymes. Both citalopram and amitriptyline are active compounds that are metabolized to an inactive compound by the hepatic enzymes. Venlafaxine is primarily metabolized by CYP2D6, while CYP2C19 plays a minor role in its metabolism. Venlafaxine is metabolized to desvenlafaxine, which is as potent in SNRI as the parent compound. Therefore, differences in metabolism between extensive and poor metabolizers may not be clinically important in terms of efficacy, but side effects would be more severe in CYP2D6 poor metabolizers. Fluoxetine is primarily metabolized by CYP2D6. Risperidone, aripiprazole, and haloperidol are commonly prescribed antipsychotic medications metabolized by CYP2D6, while clozapine is metabolized by CYP1A2. This 2004 publication in Molecular Psychiatry screened data on antidepressants and antipsychotics metabolized by CYP2D6 to calculate dose adjustments necessary to compensate for genetically caused differences in blood concentrations of the medication. This figure shows CYP2D6-mediated influence expressed as percent dose adjustments. For nortriptyline, poor metabolizers needed half the dose of a normal metabolizer, while rapid metabolizers required almost 50% more dosage. The dosage for imopramine was most variable depending on the CYP2D6 metabolic status, while dosing of citalopram and sertraline were not affected by this enzyme. The data for CYP2C19 metabolized medications was similar, with several medication doses having to be halved to achieve therapeutic concentrations. Citalopram and sertraline dosing was affected by CYP2C19 metabolic status. Guidelines for dosage adjustments are available at the Clinical Pharmacogenetics Implementation Consortium, CPIC, the Dutch Pharmacogenetic Working Group, DPWG, and the US FDA. The drug label for citalopram cautions that in CYP2C19 poor metabolizers, citalopram's steady-state Cmax and AUC was increased by 68% and 107% respectively. Celexa 20 mg per day is the maximum recommended dose in CYP2C19 poor metabolizers due to the risk of QT prolongation. The CPIC publishes regular updates. Guidelines for TCAs are based on CYP2C19 and CYP2D6 phenotypes. This is an example of the dosing guideline for fluvoxamine based on CYP2D6 phenotype. The next few slides highlight how pharmacogenetic recommendations can help prescribers identify the right drug or the right dose. Postpartum depression affects 10 to 15% of new mothers, but many cases remain undiagnosed. The patient, a 28-year-old diagnosed with postpartum depression, was prescribed 20 milligrams of citalopram. The dosage did not alleviate the patient's depression. The physician increased the dose of citalopram to 40 milligrams and then switched to 50 milligrams of sertraline. While the patient tried 2 different medications and dosages over several weeks to assess efficacy, she continued to experience insomnia, anxiety, guilt, and aggravated mood swings. With no relief from symptoms, the patient discontinued her medications and struggled to take care of and develop an attachment to her newborn baby. A Pilchuck test revealed the patient was a CYP2C19 ultra-rapid metabolizer and a normal CYP2D6 metabolizer. Both citalopram and sertraline are metabolized by CYP2C19. There would be significantly increased drug clearance leading to subtherapeutic effects. The recommendations from the Dutch Pharmacogenetics Working Group are: for CYP2C19 ultra-rapid metabolizers, monitor citalopram plasma concentration and titrate dose to a maximum of 150% in response to efficacy and adverse drug event, or select an alternative drug. The pharmacogenetics test results explained why citalopram and sertraline were not effective for the patient. She was prescribed paroxetine, an alternative drug not metabolized by CYP2C19. The patient's mood and functional abilities improved over the next 6 weeks. This is the treatment plan for a 13-year-old boy diagnosed with ADHD and bipolar disorder. The treatment includes psychostimulants and a second-generation antipsychotic, aripiprazole. The standard starting dose is 5 milligrams orally daily. After a week on aripiprazole, the boy experienced terrible nausea, akathisia, and sedation. On the other hand, his manic symptoms improved. When he refused to take medication because of the adverse effects, the manic symptoms returned. Pharmacogenetics testing revealed that the boy was a poor CYP2D6 metabolizer. The DPWG guideline recommends reducing the dose to 67% of the daily dose. The patient eventually agreed to take the medication at a dose of 2.5 milligrams. At the lower dose, the boy's symptoms were well managed by the medication and it was well tolerated. An example of how Pilchuck helped resolve a complex case. Pilchuck was used in an observational study in 2 urban Shoppers Drug Mart pharmacies. One of the participants in the study was a 56-year-old who had been prescribed several antidepressants over the past years. The medications either resulted in adverse side effects or did not alleviate symptoms. A Pilchuck test revealed that the patient was an ultra-rapid metabolizer for CYP2C19 and a poor metabolizer for CYP2D6. There would have been increased metabolism of citalopram and sertraline metabolized by CYP2C19, resulting in subtherapeutic effect. While decreased metabolism of fluoxetine and paroxetine by CYP2D6 would have resulted in high concentration of the drug at standard dose, causing adverse side effects. Under these circumstances, there are no specific dosage recommendations by the CPIC or FDA. It is possible to try high dose of sertraline or switch to a drug metabolized by enzymes other than CYP2C19 and CYP2D6, such as buspirone. In the next few slides, we will review publications on the use of pharmacogenetics in clinical trials. Major depressive disorder is the leading cause of disability in North America, and this study aimed to determine the effect of the CYP2D6 genotype on the length of hospitalization for patients treated for major depressive disorder. A total of 149 inpatients were enrolled. Patients were on average of 3 medications, with 98% on antidepressants and 65% receiving antipsychotics as well. The study demonstrated that variations in the CYP2D6 gene significantly impacted utilization of psychiatric hospitalization services, specifically leading to longer length of stay. As shown in the figure, length of stay for poor metabolizers, represented by blue bars, and normal or ultra-rapid metabolizers, represented by red bars, clearly segregate. The CYP2D6 poor metabolizers had significantly longer mean stay than normal or rapid metabolizer. The authors argued that the results of this study support pharmacogenetic testing as a clinical tool in the management of hospitalized psychiatric patients. In conclusion, they write, CYP2D6 genotyping for individuals receiving single or multiple drugs metabolized by CYP2D6 may help clinicians to avoid adverse drug interactions and to individualize psychotropic treatment. As the cost of genotyping decreases and the number of patients being treated for psychiatric conditions increases, these savings and improvements in quality of care become increasingly compelling. A 12-week double-blind parallel multi-center randomized controlled trial in 316 adult patients with major depressive disorder was conducted to evaluate the effectiveness of pharmacogenetic testing for drug therapy guidance. Patients requiring antidepressant medication de novo or changing medications were recruited at 18 hospitals and randomized to pharmacogenetic guided treatment or treatment as usual. This study included patients who had failed multiple previous treatments, and 65% of the population in the study could be regarded as refractory. Among subjects having received 1 to 3 previous psychiatric treatments, statistically significant differences were identified at 12 weeks in the percentage of patients with a positive response to treatment. Figure A shows that 52% of pharmacogenetics-treated patients had a positive response to treatment, compared to 31% in the control. In Figure B, a significant differences in the HDRS-17 score, both at 6 weeks and 12 weeks, can be seen in the pharmacogenetics-treated group, represented by a solid line, compared to the control, represented by a dashed line. At 12 weeks, the mean and median reductions in HDRS-17 were 3 points larger in the study group than in the control group. In this publication, the authors reviewed pooled analysis of the 3 prospective clinical trials, 2 open-label and 1 placebo-controlled double-blind trial. The authors conclude that combinatorial pharmacogenomics can predict response and possibility of intolerable side effects in individuals on medication regimens with significant gene-drug interactions. While some challenges remain, clinical trial data provide evidence for the potential widespread benefit of pharmacogenomics in the psychiatric patient population. As a value proposition, an intervention which offers the potential for improved outcomes combined with real-world cost savings is noteworthy. We would like to share with you some of our learnings from Pilchuck case studies. Patients on antidepressants are usually co-prescribed medications from other therapeutic areas. We did Pilchuck tests on 41 patients suffering from severe depression who were on disability. Although 4 patients had stopped taking medications due to intolerable side effects, 37 patients were on antidepressants. However, antidepressants represented only half of the net medications the patients were on. Besides antidepressants, the patients were on pain and cardiovascular medications, to name just 2 other therapeutic areas. Unless a pharmacogenetics test can resolve optimum usage for medications beyond antidepressants or antipsychotics, the test fulfills only a part of what can be achieved by pharmacogenetics. In these cases, Pilchuck, with its holistic approach, was able to resolve issues with medications in therapeutic areas besides depression. About half of the patients were advised to adjust drug dosage or switch to a different drug based on their Pilchuck report. Physicians valued the reassurance of having personalized medication guidance for these patients. The second learning is about the limitations of a pharmacogenetics test. The patient was a cancer survivor suffering from depression. His physician had prescribed an SSRI for his depression and then several anticonvulsants when he began to suffer from seizures. The medications unfortunately had very little effect on either his depression or seizures. Wanting to understand why the medications were not helping, he got a Pilchuck test. The test revealed that the patient had a normal metabolizer phenotype for his CYP2D6 and CYP2C19 enzymes and should be an ideal metabolizer for all antidepressants. Genome sequencing of the patient revealed a genetic predisposition to bipolar disorder and depression due to disruption in serotonin clearance. Although it is true for most, not all patients with depression symptoms have serotonin deficiency. Patients with serotonin imbalance cannot tolerate SSRIs, though they have normal CYP function. They may have family history of schizophrenia, mania, or bipolar disease. When treated with SSRIs, patients exhibit acute symptoms of serotonin syndrome, including seizures and anxiety. The recommendations were to stop all SSRIs and start antidepressants that do not have appreciable impact on serotonin or dopamine activity. The seizures subsided over 2 months, and all anticonvulsants were stopped. The patient has been prescribed various antipsychotics to manage his depression. In conclusion, the benefits of pharmacogenetics in mental health are: pharmacogenetics aids in the selection and dosing of an optimal drug therapy. Choosing optimal therapy can maximize therapeutic benefits, improve patient adherence, and reduce adverse drug reactions. Thank you for your time. We welcome your questions. Please contact us at info@pilchuck.ca and visit our website.